Good evening. I'd like to welcome you all to our webinar series. Today's webinar will be given by Dr. Edgar Chedrawy. Dr. Chedrawy completed an MD program from Dalhousie University in Canada, a Master's of Science in Experimental Surgery from McGill University in Canada, a Master in Health Administration from the University of Illinois in Chicago, and he is a certified physician executive. His academic clinical appointments include serving as an assistant professor of surgery at Northwestern University, an associate professor of surgery with tenure at the University of Illinois, a medical director for cardiothoracic surgery and vice chairman of the Department of Surgery, Quality and Education at Tennant Healthcare West Hospital, an associate professor of surgery and health administration at Dalhousie University, and currently he is serving as a head division of cardiac surgery at Nova Scotia Health Authority. His fellowships include the Royal College of Surgeons of Canada in cardiac surgery, an advanced fellowship in heart and lung transplantation, as well as mechanical circulatory support from Stanford University and the American Association for Physician Leadership. On a side note, Eddie and I go way back. Dr. Chedrawy, the floor is yours. Please take it away.
Thank you, Professor Karam, for the kind introduction. I'm going to go ahead and share my screen. Are you able to share? Hopefully you'll be able to see my presentation. So thank you very much for the invitation for the webinar. This is a talk on electronic medical records and the impact they have on surgeons in particular. I have no relevant disclosures to or conflicts of interest to declare. I'll start off first by looking at electronic medical records and give you a brief update on the history of it, how we reached the current state that we have, and finally give you a little glimpse into the future and what the future of medical records have in store for the healthcare profession. Second, I'd like to talk about the impact it has on surgery, and finally give you a little bit of an idea about globalization, how electronic medical records are affecting the healthcare markets throughout the world. And as Professor Kata mentioned, I'll have some time for questions at the end. You don't have to go far from Lebanon to realize that medical records actually started in ancient Mesopotamia, and many countries from Iran, Iraq, Syria, all the way into Turkey used to keep track of medical records almost 4,000 years ago. We started off in stone carving what we thought were histories of the people going around us. And this is really the origin of all medical record keeping. The Egyptians kind of took it one step further and started using papyrus to document medical records. And they really brought up a brand new concept known as scribes. And scribes were very educated people in ancient Egypt, and they really were the people that took care of the people's stories, that took care of medical histories. The first descriptions of childbirth, gynecology, women's reproductive systems, illnesses were all documented by scribes, professional scribes, believe it or not, back in ancient Egypt. However, the Greek and Romans really took it further, and they started a systematic recording of the modern day medical record. It started about over 1,000 years ago. And if you kind of think of it as the original battle between Apple and IBM, that was the battle between the Greek and the Romans. They're out there for the same purpose, but they were kind of using different languages. And if you look back at how medical records have evolved over the years, we've all been kind of using different languages, but at the end of the day, the purpose is to try and have the same outcome, to record accurately what's going on in the medical chart. This was the beginning, though, of standard terminology back to the Roman and Greek days. This is a painting from the National Library of Congress in the United States, and it shows the first ever documentation of a medical record based in the Hellenistic and classical models of the Greek and Romans, but it was done by an Arabic physician. This is Al-Razi from Baghdad. This was the first time he documented an actual procedure. And believe it or not, he took strings from a harp and used those strings to suture a wound. So believe it or not, the first ever transmission of medical knowledge of an actual procedure goes back to Baghdad, based on Greek and Roman documentation, but it was really meant to transmit information of an actual medical procedure. So surgeons have played a very big role in the beginning of the medical record. And this is almost over 1,000 years ago in the early 900s. And it really was the first translation of knowledge from Europe to the Middle East and from the Middle East back to Europe. Moving back to the West, it really was in the 1700s that the New York hospital was the first ever to start a full description of a medical record. And they documented admissions and discharges of their patients. What we know of today as the modern medical record really started back at Harvard in the late 1800s. So now we're talking just over 100 years ago. Harvard Medical School, for the first time, documented a past and present illness. They documented a physical exam. They really started what we know as the modern day medical chart, with a family history, admission, urine and blood analyses, progress notes, even a discharge diagnosis. This is really the forerunner of the modern medical record. And it was based on French and German documentations. So again, that translation of knowledge from Europe to the Middle East, went back to Europe and eventually to the North America. But this was really the first attempt at us being able to document the medical record and move it forward. It took almost 4,000 years to get to this stage, but in the late 1800s, Harvard was the first to do it. And that is one of the original claims to fame. I apologize, I didn't advance the slide there. There we go. Moving forward now to the 1900s, governments finally got involved. Right at the turn of the century in the United Kingdom, the National Insurance Act was passed, the National Insurance Act of 1911. And that was really government mandating compulsory insurance for all of its citizens aged 16 to 70. The government wanted general practitioners or family doctors to keep track of the record cards. All of a sudden, that original medical record from the late 1800s in America was being used in the UK to document how physicians were treating patients. But now that governments are involved, and more importantly, governments were paying for healthcare, the governments wanted to keep track of it. Almost every decade, there was a tenfold increase in the amount of information being recorded. Huge amounts of paper charts were now being created all across the UK, eventually all across Europe. Since governments were involved, governments wanted to keep track. They had to pay for the healthcare. They had to pay the physicians of the hospitals. All of a sudden, there was an interest from government. It's the overwhelming amount of data that was coming in. It was truly out of necessity that they had to find a better way to keep track of this information and keep track of the records that were going on. Ironically, we pushed to electronic medical records, not because we wanted to improve quality of care, but we wanted to keep track of how we were paying for care. That may not seem like a good thing from the physician or the healthcare system standpoint, but it shows you how government or business was really the push for developing the electronic medical record. So the electronic medical record, in hindsight, was created as a solution to the problems of paper charting. The solution was, number one, to deal with the overwhelming quantity of paper charts that were out there, and number two, to improve the quality of the record keeping. Hopefully one day that quality of record keeping will actually improve quality of care. So you may ask, what is the electronic medical record? Put very simply, it's the ability to exchange health information electronically. No more stone, no more papyrus, no more any other commodity, not even paper. Nowadays, it should all be done electronically. Why do we want an electronic medical record? The reason behind this big push, especially in the last 1,000 years, the real reason behind the push was, number one, to provide higher quality care or safer care. And number two, to have tangible enhancements for the healthcare organization, the business side. There's no doubt the impact IT has had on healthcare really has been on the business side, but also on the quality of care side. So to elaborate on that further, from the clinical perspective, from the clinician standpoint, first and foremost, we want accurate and up-to-date information. We want it to be complete. And most importantly, we want it at the point of care. The point of care means the actual place where we take care of patients. Having a proper electronic medical record lets us do that. There's no reason to run to find a chart. There's no reason to even have a chart. Nowadays, you can pull it up on your tablet, on your iPad, on your phone. All that information can be there and it can be accessed right at the patient. The second reason is to more effectively diagnose patients and to reduce errors. I can't tell you how many times in training we prescribe the wrong medication, we do the wrong treatment, we even reach the wrong diagnosis. Having said that, the presence of an EMR with the accurate, up-to-date information that gives us we can make the diagnosis more effectively and more efficiently, much less waste of time. The third biggest reason from the clinical perspective is that it's safer care. Much less errors, much less duplication of tests, much less redundancy. And on the prescription side, as I just mentioned, it is much more accurate. The fourth reason, and this has really been the biggest reason with our new generation of healthcare providers, is to improve healthcare communication and healthcare convenience. The generation I trained in is very different than my predecessors, the baby boomers in their 50s and 60s and 70s right now. And the people we're training, I'll talk a little bit about surgical residents, the people we're training also come from a different generation. They access information differently, they transmit information differently, and they absorb information very differently. So for an attending surgeon like me who wants to train the next generation of surgeons, I need to understand how my learners, how my trainees want to access information. The EMR, how they access information, is very different than how I was even trained. Enough on the clinical side. What about the business side? As information technology department, you know, everything digital, number one, never gets erased. It's always recorded, it's always accessible. But more importantly, as a physician, it's legible and it's very complete documentation. I'm at the stage of my career where I can't even read my own handwriting. It's gotten so bad. Electronic medical record is very straightforward. It shows us from beginning to end. Everything is complete. Everyone can read it. It's very transparent. It's very accessible. And most importantly, you can hold people accountable. The second thing, from a business perspective, as to why we should have an electronic medical record, is very accurate. There is no half numbers or scribbled out numbers. Everything is there, digital and black and white. We can streamline our coding and billing. A procedure I do in Canada can be exactly compared to a procedure done in China or India or South America. We can code it and we can bill it. And this is really the reason why the hospitals or the governments really liked it. The other reason is by having an electronic medical record, we absolutely not just ensure, but we can enhance privacy, we can enhance security, we can enhance sharing of patient data from patient to provider, to the healthcare provider, and even among providers. We can send encrypted data from hospital to hospital. And more importantly, we can learn from it. We can help with research and productivity. The fourth reason from a business perspective to have an electronic medical record is it does improve productivity. You actually become more productive per hour of time spent at work. And let's face it, it helps improve work-life balance. And we all know as managers and leaders, you know, when your employees are happy, you're happy and your company's happy and your clients are happy. So the electronic medical record, we believe these are the four reasons why from a business perspective, you don't want to have an EMR, because it will help with all those aspects. So where are we today as an electronic medical record? It's quite simple. We have a lifelong EMR up and running. Any child, almost any child born today will have access to a lifelong electronic medical record. One day that record can be scanned, it can be transmitted, it can be used to access to help that patient or that child, one day adult, healthcare in any way possible. Where else are we today with electronic medical records? It's technically and economically feasible almost anywhere in the world to have an electronic medical record. As you all know, data is transmitted across high-speed networks anywhere in the world. It can be wired, it can be wireless. We even have voice recognition to access data. We can 3D print almost any operation or any organ you want to see and show it to our patients. So the advancements in information technology have really helped medicine and the delivery of healthcare in many, many ways. Finally, it actually reduces administrative costs, and that's been proven over and over again in almost every health system that's adopted it. There is a huge startup cost. We'll talk a bit about that later on, but it does reduce administrative costs in the long run. Like I said before, the biggest push for an EMR was not from the physicians or the nurses or the healthcare workers. Ironically, it came from government, because in the end, it does reduce costs. And the more money we save, the more healthcare we can provide to everyone all across the world. This is really where the EMR has become in today's day. The United States has what they call the EMR adoption model. And you can see on your screen here, it's a very elaborate model. It's very detailed. And it shows you where in the healthcare system you stand as you adopt an EMR. So stage 0 means really nothing's installed. Stage 1 means the basics, your labs, your imaging, and your pharmacies installed. As you move up through the stages, there's more and more digital acquirement of the data, from the medications, from radiology, physician orders, physician progress notes, medication orders. Eventually, templates can be built in. They finally reach stage 7, which is what's called the complete EMR, where there's complete data transactions that are shared electronically. Data is warehoused either in your institution or up in the cloud. And more importantly, there's data continuity. So if a patient comes in today with a heart attack, comes back 6 months later with another heart attack, we can access that previous data and use it to treat the second heart attack. If they go for surgery, we can look up their medical record from before, take that information, and apply it to the next one. The whole purpose of this is to have, as I said before, real-time, up-to-date data at the point of care. That reduces errors, makes healthcare safer, makes healthcare more cost-effective, more cost-efficient. It's the combination of those two industries, information technology and healthcare, coming together that have made all this possible. So this is the US electronic medical record adoption model. It's been quite used. It's been spread throughout the world, and I'll show you the Middle East version of it later on. Well, what about the future? You know, the future of EMRs, really, you have to look at it from 3 perspectives. The first, as I've said, is the patient's perspective. Patients want more access. They want more control. They want more privacy, and they want more security. Healthcare, we don't like to think of it as a service industry, but it is a service industry. And this is what we owe our patients. They have complete access and control of their medical records. They want to make sure no one else can see their medical records. All that will be enhanced. And in the future, it's only going to get bigger and bigger. The second thing the patients want is cloud-based technology. And one day it will all be in the cloud. There will be no more data warehousing in our hospitals. And we're going to have graphical user interfaces where the patients can access it very easily. They'll even be able to access it from their mobile device. That's a very important thing. People want that ease. They want that level of satisfaction on their healthcare. Finally, as I mentioned, it will be a lifelong electronic medical record. Your genetic data up until the day you die will all be stored, and you can have access to it even with interpretation of results. The role of the physician will actually be less and less as time goes on. And then finally, EMRs won't just be used to store information, they can be used to collect information. And one day we're going to have biosensors on patients, and that'll improve our patient monitoring. I'm sure some of you have an Apple Watch or a Fitbit. You can check your heart rate. You can even run an EKG off of it and see how your heart electrical system is working, all from your wrist. So these will happen more and more over time, and you'll see as time goes on, these will be more and more prevalent. But from the patient standpoint, this is where the electronic medical record is going in the future. What about from a population health standpoint? The beauty of the electronic medical record is we can finally all speak the same languages. We can have internationally accepted standards all across the world to treat diabetes, to treat heart failure, to get patients ready for surgery, to transfer patients all over the world. If you're in the Middle East and you want to come to North America for healthcare, the information is transmitted automatically. All that can be done. More importantly, we can enhance our research abilities and our education opportunities. We can, sitting here in Canada, teach medical students virtually in the Middle East and in India and China and all over the world. We can use the data to be stored, access for everyone to see. We can start finally collecting what really matters, not just medical care, but health, social data, economic data, behavioral data, and ideally even link it to environmental data. So the EMR in the future, from a population health standpoint, will be even more valuable than it will be for individual patients. If I do 40 endocarditis operations a year to replace heart valves, and in Brazil they do 500, why can't I learn from the 500 in Brazil? It won't just be left up to the medical literature. It'll actually be in the electronic medical records, and that data easily transferred back and forth between us and Brazil. The third aspect in the future of EMRs is something I'll talk to you more about in the spring, which is artificial intelligence. Like I said, we're not just going to collect data, we're not just going to share data. Artificial intelligence with clinical decision support modules, we're going to use that data to make decisions. This is the role of AI in healthcare that's coming down the pipeline. We won't just monitor the adverse events you've had, we're going to learn from them for you as a patient and make decisions on them. All that the EMR will do one day. Nowadays, with big data, with big analytics, data storage, everything else that's going on, we may one day reach what's called precision medicine. Precision medicine is where it is exactly tailored to you, the patient. We can use that to forecast what's going to go on for you as a patient, and maybe ideally even for the general population around you. We'll be able to finally do what's called predictive modeling and decision optimization, where we can take your individual data as a person, run it through the algorithm. It'll give us a diagnosis or a treatment plan. And even more important, not just for you, for your relatives, for your families, for friends, or people in your community. So the potential of artificial intelligence from the electronic medical record is unlimited. As I said, we'll talk more about that in the spring with the second webinar that we do. So enough on the history, the current state of the EMR, and like I said, my vision of the future for the EMR. What impact does the EMR have on surgeons or surgery? You know, surgeons are very simple creatures. We love the operating room. It's the best place in the world. You're in your pajamas, the air conditioning is on, the music is on, the lights are dim, we're operating. It is the funnest place in the world to be. It is the only place we want to be. In fact, if you take us out of the operating room, we get very upset, and we like to stay there all the time. My specialty is cardiac surgery. You can see here in the top left, the standard incision for open heart surgery. Then you can see the small incision on the patient's right side of the chest. On the bottom left, you can see an aortic aneurysm we're about to fix. On the top right, you can see a valve we're replacing. And on the bottom right, you can see a minimally invasive aortic valve that we're replacing. That's what we love doing. We love being in the operating room, focusing on patients, taking care of patients. A lot of people think, oh, it's just a 2-hour operation, 3-hour operation. Every hour of our day is special. Every hour is precious. And when you take a surgeon out of the operating room, or any physician for that matter, it truly does affect their work and their productivity. This here is my team on the next slide. And on the right, you can see my fellow Ahmed Al-Faraj from Dammam, Saudi Arabia. He's a cardiac anesthesia fellow. In the middle of the picture, kneeling on the ground, is Dr. Ayman Hendi, who's our cardiac anesthesiologist. And then all the way starting from the left, you see our nurse Megan. You see my fellow Dr. Abdullah Bagafar from Jeddah. You can see my colleague, Dr. Hashim Alatar from Jordan. And next to me is our 2 other nurses, Pam and Emily. The reason why I'm showing you this is how many people come in for every operation that we do. Doesn't matter whether it's a small operation or a big operation, at the end of the day, we need this much people in the OR. Having an EMR is important, and I've showed you the benefits clinically and business-wise for the EMR. But for the individual practicing surgeons like myself, if it's not truly going to make care better, higher quality care, if it's not truly going to save money, then I don't want to leave the operating room to do the EMR. So we have to prove that EMRs save people's lives. You have to prove that EMRs save money, or else for the practicing surgeon, the impact on surgery, it will not be good. Having said that, we know that EMRs do all this. This here is a study from Lin from Taiwan, and it looked at the association of the electronic medical records and healthcare quality. And this is an observational study of 5 years in the Taiwanese community looking at EMRs. And there's a big number of patients, 260,000 patients. And of the 260,000 patients, they compared those that were in hospitals with full EMR versus those that were in hospital with no EMR. And the results are quite obvious. In the full EMR hospital, there was a lower inpatient mortality. And it may not look like much, 3.0% versus 3.29%. But you have to realize a mortality reduction of 0.2%, that's 500 deaths difference in this study. 500 people died in this study in the hospital that didn't have an EMR versus the one that did. There was a lower risk of readmission, almost a 0.8% lower risk of readmission. Readmissions cost money. Lowering readmission saves money. So that's a big deal as well. Then finally, they were even able to prove there was a lower risk of a 48-hour postoperative mortality. Patients that die within 48 hours of surgery, by definition, die because of the surgery. This study showed that they actually died not because of the surgery, they corrected for everything else. They literally died because of lack of information transfer. So this is a very powerful study showing that the presence of an EMR saved lives, saved money, and lowered readmissions. You could argue that this is an observational study. Our next study here is a meta-analysis done in the European community. Campanella did this study in Italy, and it was a meta-analysis of over 23,000 citations, and 47 articles fit the criteria for this meta-analysis. And it was very important. This was in the European Journal of Public Health, and it reduced documentation time by 22% having an electronic medical record. Not only that, there was a higher chance of guideline-directed medical therapy. Adherence to guidelines went up by almost 33%. There were much less medication errors, and there were much less adverse drug reactions. So not only did you prescribe the right drug if you had an EMR, you were less likely to have complications of prescribing the drug. So again, a very powerful study telling us that the presence of electronic medical record does improve quality. There are actual, tangible, and realizable differences in hospitals that have electronic medical records versus the ones that don't. So again, a very big plus and bonus for hospitals with electronic medical records. Well, that's all fine, but like I said, at the end of the day, I'm a surgeon. And if you're going to take me out of the operating room, I want to make sure it's for a good reason. So this is a study from Baylor Scott and White Healthcare in Texas, done in 2016. They looked at how surgeons view electronic medical records. And like I said, we're a pretty tough crowd. This is a surgery group 3 months after the electronic medical record was implemented. They looked at 59 surgeons, 24 were senior surgeons, 35 were trainees. And they used a very simple Likert scale. The Likert scale is a scale of 1 means I disagree, and a scale of 5 means I totally agree. So the closer you are to 5, the more people are happy and they agree with the statement that you said. The results were pretty disappointing. The only real positive comment was here, 3.9. EHR, the electronic health record, is better for billing than it is for clinical documentation. The surgeons all pretty much agreed it's not that good for clinical work, but it's really good for billing. It's really good for the hospital to keep making money because everything is documented. The worst reports on the Likert scale really go back to the score of 2.6 for patient satisfaction, and also the score where it did not really accurately or completely convey what the physician was thinking. So these surgeons, 3 months into it, pretty much said the electronic medical record is good for billing, it's good for business, but it's not good for care. That's how we as surgeons initially perceived the electronic medical record. We felt it was more of a hospital corporate tool as opposed to a clinical tool. So early on in the game, it really was a hard sell, especially for the surgical community. The question comes up, well, we're not happy with it. Let's try and understand why we're not happy with it. And this is a study from Durham, North Carolina in 2021. This year, Morgan Cox looked at how much academic surgeons, so people like me that work in an academic health center, how much time do you actually spend on it and how is it affecting us? Well, they looked at 51 general surgeons, and on average, the average general surgeon spends 2 hours a day or 14 hours a week on the electronic medical record. In fact, the top 15% of the users, top 15, spent about 4.5 hours a day on the electronic medical record. So 4.5 hours a day, that's almost a third or half of your day, depending on how many hours a day you work. And even worse, 2/3 of this occurred on site, but almost a third of the documentation occurred off site, or for most people that would be at home. So it's like we're not even leaving work anymore. Whatever we don't document at the hospital, we wait till we get home, then we document it at home. And it's hours after hours of documentation. So yes, it does help with billing. It does help with coding. It's going to be a great tool one day. But right now, 2 hours a day, you realize an open heart operation is only about 3 to 4 hours. That's half of that I would have spent doing electronic medical record. It's a huge amount of our time and investment. And in fact, multiple times it's been quoted that the EMR is contributing to physician burnout. And burnout is a horrible thing for anyone. And for surgeons in particular, we don't do well with burnout. But the reality is it is there and it is contributing. It is contributing quite a bit of time. Moving forward on the topic of burnout, Tajirian and Stojopoulos in Toronto did this study last year that specifically looked at physicians and their learners, their trainees, when it comes to burnout. And they pooled over 200 people. And this was a cross-sectional survey. And of the 176 physicians and 32 learners, 25% of the attending physicians complained of one or more symptoms of burnout. and almost 20% of the learners complained of burnout. So almost a quarter of all of the people that are using the EMR are complaining of burnout. And the reality is, of the people that did have burnout, 3/4 of them said, I'm burning out because of the electronic medical record. So this wonderful tool that's helping us advance healthcare, advance the business of healthcare, it is burning out a lot of the staff. And it's something we have to be aware of, and it's something that we have to be cognizant of, because if it is going to stay, and there's no doubt it's staying, we need to find a way. We need to find somehow to coexist with the EMR so we can still do our surgery and still be able to document, do what everybody else wants us to do. I bring this up because at the end of the day, it's not just about us. You know, this is me here standing on the right, and to my left, you see our cardiac anesthesia fellows I mentioned earlier, Dr. Al-Faraj from Dammam. Next to him is Dr. Mohammed Mashat, our cardiac surgery chief resident from Riyadh. And next to him is Catherine Dehai, who's our chief resident from Quebec. At the bottom, you see our fellow, Dr. Fernando Gaiten Cortez, who's from Mexico City. You know, we have a mission to train all these people. And if we're spending more and more time documenting, we're spending less time in the operating room. On the top right here, you can see a picture of someone you're putting an artificial heart in. And this was a heart failure patient who was could not be transplanted at the time. We put an artificial heart in him, and 3 years later, I went back and reopened him and took the heart out and transplanted him. And that's the picture of the transplant. So to take us away from the clinical work for documentation is a big deal, and it affects all of us, not just the surgeons, but the trainees as well. So as I said, it's a big deal for us to train and do research and education, and the EMR has to be a fundamental part of it. To finish up on the resident trainee side, you know, Maloney in Carolina's Medical Center in Charlotte, North Carolina last year at the American Program Directors Association published this paper on how much time is actually spent by the surgical residents. And didn't matter which specialty, whether you're in general surgery, orthopedic surgery, or gynae, it was almost an hour to 2 hours every day documenting. And like I said, surgical residents work hard, at least 12 hours a day in our system, and it is quite a bit of time. In fact, if you look at where they spend their time, it didn't matter whether you were an intern, a junior resident, or a senior resident, a lot of your time was spent on the EHR, the electronic health record, and it's almost 20 to 25 minutes per patient. And if you look at surgical versus non-surgical trainees, the surgeons, as always, don't have much to say. We try and do things as fast as possible, but the trend is pretty much the same. You know, the medical residents, the non-surgical residents, where documentation is very much more important for them than for the rest of us, they can spend up to 20 minutes per patient. My guys spend about 6 to 8 minutes per patient. But the reality is, whether it's a chart review, whether it's documentation, or even order entry, all of this is taking the trainees away from what they like to do most. And what that is to operate and take care of patients. So I'll finish up on the EMR impact on surgery side by saying it has affected our practice as attending surgeons. It's affected the way we treat our residents. It's affected the way our residents train. It's affected the work-life balance. So IT has had a positive impact on healthcare, but it has been at the expense of the work-life balance of a lot of the practicing physicians. And the nurses will tell you exactly the same. It has affected them. Well, just to finish up and leave some time for questions, I want to talk a little about globalization and how the EMR has affected the worldwide healthcare community. You know, there's no shortage of EHR software out there. And on the top here, you can see the top 6 competitors or vendors for electronic health records. All of these have to have a few common interests or common achievements. And as I said, as long as you keep in mind the EHR, the electronic medical record, is all about the patient, you won't go wrong which vendor to pick. And which vendor gets picked where depends on politics and finances. At the end of the day, though, they all have to circle around one thing, which is the patient. It's all about the patient. It was great that the UK government wanted to keep track of people, how much care they were receiving, because they had to pay for it. But it's even better when we can use that information to provide better care. So it's all about the patient. Everything you see on the right of the screen is about the patient, the history, the test results, the orders and notes. On the left, you see the billing and the demographics, which is what the governments want and the hospital administrators want. But at the end of the day, all of these mandates have to revolve around the patient. At the end of the day, that's all that matters. And in whatever electronic medical record you have or you want to push, As long as you keep that in mind, you're never going to go wrong. This is the market penetration of EMRs by US dollars in billions across the world. And you see on the left side of the screen here, in 2018, it was about $10 billion in total, most of which in North America. The 2020 data, which is just before COVID hit, was about $14 billion spent on an EMR. Just look at the projected EMR in 2025. So you're talking in 4 years or less from now. North America will still be the lion's share, but Europe is picking up, Asia Pacific is picking up, and yes, Latin America and the Middle East are also picking up. It's looking at becoming a $20 billion market just in the next 4 years. So it's a growth of almost 30% in 5 years. That's pretty good for a global market. So if you were thinking of an EMR, the question really comes up, which EMR is right for your hospital, for your health system, and how would you approach it and set it up? If you look at the dominant players in the US market, and this is the 2018 market, almost half the market is filled by 2 vendors, Epic and Cerner. And I've worked with Epic. I became an Epic super user in 2004, my first job. I had learned how to use Epic. And then in my second job in 2007, I switched to Cerner. So I've used both of these systems throughout the years, and they both work well. Meditech is great. I use that at one of my hospitals in Chicago, and I used to work there. So which vendor you use goes back to your local culture, your local appetite for how much data you want to control, how much order entry you want to put in, how much documentation. And obviously you have to warehouse the data and store it somewhere. So all of this has to be looked at. But in the US market, half of it is literally Epic or Cerner as vendors. The Middle East is a little different. If you look at the Middle East market, and this chart is 2 years old, it hasn't changed much since COVID. There is no dominant player in the Middle East market. Cerner is about 15% as a US company, and Dallas Agfa is another 13%, and the rest of the players really are marginal. So the European market is very scattered, the Middle East market is very scattered. And it doesn't matter whether you're in Lebanon or the rest of the Middle East, or even if throughout Europe, there actually isn't a dominant EMR vendor. They're mostly homegrown systems, and I know throughout Lebanon there's some homegrown systems, and even in the Gulf there's some homegrown systems. But the point I'm trying to make here is it has to be adaptable to your local culture, your local infrastructure, and that's where technology and economics come into play. But you know, it's a very big contrast between North America and the Europe Middle East market. Having said that, the Middle East has its own electronic medical record adoption model. And you see here, it's no surprise, looks very similar to the American model. The steps are the same, but there are a few steps that are different. You know, one is for PACS. You see here in stage 5. PACS is the imaging system. And in the Middle East, most hospitals put PACS in stage 5. In the US, it was in stage 3. It was very important to reach a remote imaging system early. And the reason why is in the States, imaging is a huge business. It reimburses well for the hospital, but also a lot of decisions have to be made quickly. A lot of emergencies are dealt with a lot quickly if the imaging is immediately available. So in the US market, imaging became a stage 3 issue. In the Middle East, it's a stage 5 issue. The other is for medications. On this screen here, in the Middle East version of EMR adoption, medications closed loop didn't happen until stage 6. Medications ordered, physician prescribes it, orders it to pharmacy, nurse picks it up, nurse gives it to patient, goes back and gets documented. That closed loop doesn't happen until stage 6 in the Middle East. In the US system, it happened in stage 5. And the reason why is lawsuits happen, drug reactions can happen. And again, it was just much more priority in the US market than it is in the Middle East market. Having said that, the models look very similar, and adoption of the EMR is only going to continue, again, based on economy and technology that can limit us anywhere in the world. Just to finish up, I know in November 2018, the AUB went live with Epic, and I think that was a great accomplishment. I think they did a great job. I knew a bit about the implementation of it and the design of it. I've done consulting work for Epic in the past, so it was nice to see that it was laid out, and I hope to see more electronic medical records throughout Lebanon and the region. In 2019, Middle Eastern hospitals reported which ones were at stage 6, which ones were almost near the full EMR of stage 7. And In 2019, you had 15 hospitals in the Emirates, you had 13 in Saudi Arabia, you had 2 in Qatar, and you had 1 in Egypt that all reached stage 6. And I can tell you, stage 6 implementation is almost world-class. And it's great to see that. It's great to see that dissemination throughout the Middle East. I know quite a few of these hospitals, especially in Saudi and in the Emirates, they did that not just for their local healthcare markets, they did that for their regional healthcare markets. That's how they transmit information for patients coming there from Europe, from the rest of the Middle East, from Africa, and from India and China. So again, congratulations to them. They did a great job by doing that. And I hope one day to see it spread throughout Lebanon, because it will help not only take care of your local patients, the patients in your immediate area, but it improves your secondary and tertiary market areas if you want to market for patients outside of Lebanon and the Middle East. So just to finish up, I want to thank you for your attention. As we talked about, the electronic medical records has quite a long history, from the days of papyrus and paper charts all the way to the digital transformation or revolution. You know, as I mentioned earlier, it really boils down to just 2 things. Clinically, does it improve quality of care? And business-wise, it improves record keeping, billing and coding. It does lower costs. But I will caution you on the business side that lowering costs has come at a cost to the physicians and nurses that are practicing, more so on the surgery side than anywhere else. And again, thank you for indulging me for a bit of globalization conversation. And I'll be happy to thank, first of all, people that helped me prepare for this slide. Miriam Saliba, Emergency Department Officer at the AUB Medical Center, and Layal Hnaini, the Medical Health Sciences Librarian at the AUB, helping with some information. And I want to thank my old friend, Professor Marcel Karam, the chair of your IT department, for inviting me for this lecture. So thank you very much.